Good afternoon, everybody. My paper is about simultaneous acute bilateral BRVO, possible causative associations, I wouldn't say etiologic, possible causative associations and clinical outcomes. The aim is to describe the possible causative associations and the pattern of complications in bilateral simultaneous branch retinal vein occlusions. We had 22 subjects in the age group between 28 and 76 years, 14 men and 8 women. It was a prospective observational case series. And the veins involved were either the main vein, branch vein, or a tributary vein. 12 patients had pre-existing diabetes mellitus and hypertension at presentation, all presented with sudden onset of visual symptoms, blurring of 1 to 8 days duration. And the features of vein occlusion were obvious. In branch retinal vein occlusion were obvious in all these patients. It involved the arteriovenous crossing in all but 2 patients where it was along the length of the vein. Multiple BRVOs were seen in 1 patient. To authenticate the fact that these photographs that I will be showing are of the same patient, the optic disc configuration, the congruity of the disc, as well as the age of the hemorrhage, the appearance of the retinal bleed in both eyes, they authenticate this fact. Exclusion criteria: those who had old BRVO in one eye, or sequential BRVO in the 2 eyes of more than 1 month duration, or patients with CRVO or hemi-CRVO in the other eye were not included in this group. Now, a routine workup for all retinal vein occlusions, as is normally done, was undertaken even in patients who were young. It is generally thought that young patients have other etiologies, and diabetes and hypertension are not so common in the younger age groups, and that they have other thrombophilia states. But we did find that many youngsters in our group also had undetected hypertension. One lady was on OCP. After history and review of systems by an internist, additional tests were ordered in a tailored manner, and these include homocysteine, ANA, chest X-ray, ACE levels, APLA, HIV status, hepatitis B and C, and serum protein electrophoresis as well. Coming to the results, hitherto unknown occult predisposing factors were found in 10 patients, and open angle glaucoma, which was not diagnosed up till that point of time that the patient presented to us, was diagnosed in 3 patients for the first time. The commonest underlying cause was hyperhomocysteinemia. 1 patient had an ANA positive, and that was again confirmed by a ANA profile, and APLA was also positive in this patient. Leukemia was detected for the first time in 1 patient, sarcoid in 1, renal artery stenosis in a young undiagnosed hypertensive, and hyperviscosity from polycythemia and thrombocytosis was detected in 1 patient each. Now, these are some pictures of the patients that we saw. This was a patient who had bilateral vein occlusion, but not at an AV crossing, but along the segment, along the length of the vein, with perivascular exudates. And this patient had sarcoidosis, and with treatment of the systemic condition, the fundus findings abated, but later he needed laser for the peripheral neovascularization that he developed in the left eye. These are more photographs of patients who had bilateral simultaneous branch retinal vein occlusions. This was a patient who had multiple branch retinal vein occlusions in both the eyes, and he was diagnosed to have CML for the first time. As I alluded to in my results column, there was more than a 50% incidence of neovascularization in either of these eyes, and this was one such patient where the left eye had extensive capillary dropout in the upper temporal quadrant that stabilized with laser treatment. More pictures of patients with bilateral BRVO. This was the lady with SLE positive findings. She had a nasal BRVO in the right eye, and BRVO along the upper fundus in the left eye, not involving the macula. And she had extensive capillary dropout areas, and she was referred to an internist for anticoagulation. More pictures again. This was a patient with thrombocytosis who presented with bilateral vein occlusions, and even as we were trying to get her investigated, she developed more hemorrhages in the superior fundus of the right eye, and she needed laser photocoagulation for the extensive capillary non-perfusion in the new vessels. These are the last set of pictures of a patient who had bilateral vein occlusions, and this was a patient who had polycythemia. The average follow-up was about 4 years, with a range from 5 months to 6 years. As I said, 8 patients developed new vessels in one or the other eye, so a higher incidence of new vessels because a common underlying factor was found in nearly 50% of these patients. 12 patients developed recalcitrant macular edema stubborn to various treatment modalities, and anti-glaucoma treatment had to be started in the 3 patients who were diagnosed to have OAG. Systemic anticoagulation in the SLE patient and follow-up with hemato-oncologist in the others was advised. So in conclusion, acute simultaneous BRVO needs a more comprehensive evaluation and not necessarily restricted to the microvascular group that we've seen in elderly patients, and OAG is not to be missed, and complications either in the form of new vessels or recalcitrant macular edema, possibly because there is a strong underlying causative mechanism operating, complications are more likely to happen in one or the other, in either of the 2 eyes. And additional relevant tests as dictated by systemic history and the review of systems is necessary. Serious and potentially life-threatening conditions were found in our group in nearly 50%, slightly less than 50%, and therefore it mandates aggressive search for additional causes in these groups of patients. Thank you very much for your patient hearing.